Welcome all for the next session, Comprehensive Management for Watery Eye. So till now we were learning lots of things, and now we'll continue learning about the lacrimal surgeries. Some many more newer techniques. So many more newer techniques, including small incision lacrimal external DCRs. So be with us. I promise once you complete this session, you yourself will be able to deal all kinds of problems related to watery eye. So I invite Dr. A.K. Grover sir as my co-instructor. Sir. Sir. Grover sir. Sir, please take your seat. I invite Dr. Nitin Trivedi sir. Dr. Arun Samprathi will join us shortly. And we have another speaker, Dr. R.P. Moria. So, Dr. A.K. Grover sir doesn't need actually any introduction. He doesn't actually need an introduction. All ophthalmologists knows him. He's a past president of AIOS as well as he's a past president of oculoplasty. So all oculoplastic surgeons are fan of him. And at the same time, right now, he's a president of Ocular Trauma Society of India. Rather than speaking more about him, let's listen him. He'll take care of Conjunctivo Dcr and he's master of all the surgeries, but I am fascinated by his proximal obstruction surgeries for lacrimal passages. So, over to you, sir.
लगा ही रहने देते लास्ट स्टॉप पर यहाँ फर्स्ट स्टॉप. Thank you, Dr. Shreya. It is wonderful to be a part of your session and for the opportunity to talk to people on the upper lacrimal system obstructions. So the upper lacrimal system obstructions, for those of you who were present in the earlier session, are the most difficult to tackle, unlike the dacrocystorhinostomy, which we are more used to. Of course, that's not an easy surgery either, but the upper lacrimal system obstructions have results which are less gratifying and often require innovative solutions as compared to the distal obstructions, where lacrimal sac surgery has relatively predictable results. So the lacrimal obstructions, we consider them as proximal when they involve either the puncta with either congenital absence or an acquired obstruction, or if one canaliculus is obstructed due to a process of inflammation or trauma or any of the other etiologies that we'll talk about, or both canaliculi may be obstructed, which changes the management, then common canaliculus may be involved either laterally or medially. Some of the medial common canaliculus obstructions can be tackled in a different way by just intubation, but the lateral ones become relatively more difficult. The distal obstructions can be the sac lumen itself may be obstructed, or what is more common is the nasolacrimal duct obstructions. And then there may be obstructions at the nasal wall itself. Sometimes being caused by nasal pathology, including inferior meatus problems. The punctal and canalicular stenosis may be either congenital or acquired due to various causes such as trauma. You can have a punctal agenesis or punctal membranes, and there may be absence of lacrimal passages itself. I mean, not just the punctum, but the rest of the canalicular system may also not be developed. Now, the punctal and canalicular stenosis can occur due to a number of causes, and one of the commonest is unknown etiology. But what we've observed is that meibomian gland disease is playing a major role in these cases. We know of post-infective such as herpes simplex and trachoma, cicatricial as in OCP, Stevens-Johnson, and chemical burns. Some drugs tend to cause this obstruction, and following previous surgical procedures such as DCR or our syringing, which is traumatic, or probing, which is traumatic, can also lead to iatrogenic one, and of course trauma of various causes. So meibomian gland disease, as I said, is a very common cause in our country for canalicular and punctal obstruction. So treating this in time often prevents the obstruction of canaliculi. And you need to grade the severity in order to decide what kind of management patient will need. Of course, you all familiar with the dye test, fluorescent dye test, where you see the emptying of the sac, or the Jones dye test, which is a two-step procedure to see the whether the upper or the lower system is involved, irrigation and probing, and nasal endoscopy. These are all important tests, so we'll not elaborate on these. So the management can be either conservative measures, such as taking care of the primary cause of inflammation or the drug, or using the lubrication. You can treat meibomian gland disease, or stop the glaucoma drug which you think may be an offender, change it to something else, and then the botulinum toxin injection. So conservative measures help in a number of cases. Helping them with use of a glass is often very helpful, and in those where it is combination of overproduction and obstruction, as in meibomian gland disease, it may help if they're less exposed to direct draught of fan or AC, so that the surface dries less and produces less water. And wiping should be taught well, so that they wipe it upwards and medially, so that the laxity of the passages does not increase. So let's look at the technique of injection. So this is where you inject, as the question was asked, into the lacrimal palpebral lobe of the lacrimal gland. If it doesn't prolapse spontaneously, you can put a little pressure on the globe and do it. Stay well away from globe using a 26 needle, and don't do more than 2.5 units. So surgical, there are a number of ways of managing it. Perforated punctal plugs are useful but not easily available. Once FCI merges with Zeiss and makes it available to us, it may be easier. Then the 3-snip procedure is less often used now, as I think the video is not working. So
Excuse me, can you help? Video is not.
no, maybe it will work. I'll just it's not have opened. So let's
This one we want to
see the 3-snip
like
procedure.
to
Okay.
see the videos. If you can help, if you could help.
Okay, it's working now.
Yeah,
Working.
fine. Thank you.
So you try and see if you find the passage becomes open with a membranous obstruction, then you don't need a 3-snip. But if it does not, then you convert it into a vertical snip from the punctum, presumed site of punctum. And if it becomes patent now, you don't need to do a 3-snip. If it doesn't become patent now, then you move further in the direction of the presumed horizontal part of the canaliculus, and it can remain as a 2-snip if you find that you are now able to intubate it. But if it doesn't, then you may remove the tissue in between in order to get rid of all possible obstruction and then carry out your intubation. You have to try and see if it is an obstruction only of the proximal part, then you will succeed. If it is extending further, you will not. Fortunately here, we are able to go through. We find that we are getting up to the hard stop, so we can go ahead and proceed with the intubation at this stage. So canalicular stenosis, you fortunately now have the trephination, but suitable cases are only those where there is a localized obstruction. And then you can go first open up, put a punctum dilator, see where the obstruction is, and then use a Sisler trephine. Now initially it is covered by a sleeve. You will go up to the obstruction site, pull back so that the sleeve is gone, and now the cutting part is exposed. You go through that. Once you overcome the obstruction and reach the hard spot, you know it is open now, and then you do your syringing, and you can now go ahead with your mini Monaca or any other intubation. So canaliculodecrocystorhinostomy is applicable for distal common canalicular blocks at more than 8 millimeter, where you overcome the obstruction, open up the sac. You can sometimes create a small flap of the distal common canaliculus to anastomose through the sac with the nasal mucosa, open up, do like a DCR. Briefly, now we'll just show some of the videos of Conjunctivo Dcr technique, which many of you have already seen as the last talk in the previous session. Now the Pyrex glass tubes, or one of the glass variants, is the only one that works well because it has the required capillarity and biotolerance and does not clog easily. But disadvantage is that you need to have the entire inventory, and the set available from abroad is very costly, so you can get it indigenously made. Now stop loss tube, where there is a sleeve to prevent its coming back. This is a flexible tube which bends when you're pushing it in but doesn't let it come out towards the conjunctival sac, has been shown to decrease extrusion. This is the one that we get made from Fatehabad, one chudi maker, with a sleeve and with a bevel at the distal end, and we pass it. The surgical technique is simple. Like a routine DCR, you close the posterior flaps if you made them. This is the anterior flap which is visible, which will be sutured later, but you now know where to go in between the two flaps. You excise the caruncle by a little incision in that area. This is the area where you want to start your opening, and you need to give a direction down and inwards. So you first pass a needle, bent needle, which is a 21 gauge or something, and in a direction which gives a gravity for the passage of the tube. Once you know that you've been able to pass the needle as a director, you can then pass your Graphis knife in through that, or a 15-degree knife through that, so that you know that you've created an opening. Make it a little wider, and then pass a probe along that till it reaches the septum in that direction. Hold it with the forceps at that point and see how much is the distance. 2 millimeters short of that, or you can look endoscopically and see that you must stay short of septum, not obstructing the septum. Then pass the tube with a thick probe within it which supports it, which gives the force to go through that narrow opening that you have made, and go in the right direction so that the tube goes through to the nose, and in the right position. Endoscope, if it is available with you, you can check the right positioning in the middle meatus and make sure that it is functioning and not getting obstructed by and then you can suture the anterior flap. Post-operative care is the most important. You have passed a Prolene suture through it, which both the ends, then you pass through the lid so that the tube remains in position, and then do a syringing through the tube. Post-operatively, besides anti-inflammatory, local steroids, nasal decongestants, what is important is to tell the patient not to blow nose, and whenever they sneeze or blow, they must protect the tube by putting a little finger over there. And they must learn to breathe in after closing nose and mouth so that they're able to maintain the patency. Early post-operative, there are likely to be mucus cloggings which need to be cleared. And they must follow up if they feel any obstruction. Because early post-operative, because of inflammation, obstruction may occur with mucus which need to be opened up. And if they come within a day of extrusion or something, it can be easily passed. You need to guard against obstruction, extrusions, inward migration, getting covered with epithelium, or irritation by tube causing local granulomas formation. If you use a suture other than non-reactive materials like proline, you may get a granulation here. So these are the various problems that take place. Results can be quite gratifying, but with a lot of work. Sometimes you need to do a syringing through that in the early post-operative period. Patient needs to be available in town for a couple of weeks, and then make sure that if you get inward migration or granulations, you snip them. So early post-operative difficulties need to be tackled well. Long-term results are very good. So once it is patent and they've learned to breathe through it, I have patients coming for 25 years, 30 years now who are doing quite well and happy with it. But direct passage of the tube can also be done now, as you'll see. Here we're looking at the obstruction with needle and syringe, and then we'll decided on a direct approach where we can use the stillet that is available to us from cardiology. You've seen the direction with the needle and check nasally that it is the needle is in the right position with the endoscope. And then you pass this stillet to create a wide enough opening by going through the bone, and then you find the position endoscopically and pass your tube. After you measured the size, pass the tube with after having passed a suture through it, as we said, proline suture through the lumen, where you will put the knot within the lumen, and then you can pass the tube with the support of a probe which is fitting snugly with it. Once it has gone into the right position in the nose, then you close that area and you can get a tube in position. So the proximal canalicular obstructions require a great deal of thinking and innovation for you to work, but they can be tackled with a fair deal of success. Thank you very much. Sorry for having
Thank you so much, Professor Dr. Grover, sir. For my curiosity, I just would like to, how do you tackle proximal lacrimal passage block, as well as there is card sac? The sac is also obstructed, so how you manage?
So in most of these cases, it would be best to do a Conjunctivo Dcr rhinostomy only. And if you can open up the sac and try and tackle that just as you would do a failed case of Dcr rhinostomy by removing all scar, just identifying the area in front of the common canaliculus anteriorly, and getting as big a virgin nasal mucosa as possible. By opening up additional bone anteriorly, you often get a very good mucosal flap as well. So just anastomose those two, use some mitomycin C in that area, and then do a Conjunctivo Dcr rhinostomy like you would.
Thank you, sir. And do you take any precaution not to happen on the dry eye? Because that can sometimes, this John's tube, there's no pump, so sometimes it leads to dry eye. So do you add something?
Generally, the basal secretions are not compromised. If your cause is not one where there has been a scarring of the, like for example, in a condition like scars due to chemical burns or something. If it's not a cause like that, you would have accessory glands functioning adequately to give you a surface lubrication.
Thank you, sir. Anybody, if you have any question for Professor Dr. Grover, sir?
what you said is the application of the the mucous membrane sometimes works very well. So around the tube you can put a mucous membrane graft and put it inside. So the chances of
Nitin has done a
acceptance
few
are
cases
much
like
better.
that.
Yeah,
Yes.
right.
Where exactly do you put it?
Yeah, along the tube, you are putting the tube, so along the round, you can round it with this thing and put it inside. After sometimes you can even remove the tube, but
So do
the
you
mucosa
suture
will,
that mucosal
it will
flap?
be
right,
Anteriorly?
mucosa will line the opening which we have made. So that will be accepted better sometimes.
Taken from the lip?
Yeah, oral mucosa.
MMC.
That's a good idea, very good idea.
Thank you, sir. Thank you so much. I invite Professor Dr. Nitin Trivedi, sir. He is Dr. Arun Samprathi, sir. Can join us. He is also past president of Oculoplasty Association of India, and he is eminent surgeon practicing at Ahmedabad. He is director. He was director Nagri Hospital, Ahmedabad also. He'll be mainly speaking on conventional external DCR along with some slides.
Good morning. We had a very good
Endonasal
discussion on the
Dcr.
proximal part of the lacrimal apparatus. And when we come to the main part of the lacrimal apparatus is the lacrimal sac and the nasolacrimal duct. It is one of the commonest surgeries which an oculoplasty surgeon does. So there are so many changes nowadays in the process, and I think we'll have to see the things which we are doing previously and what are the things which we can do later on also. So this is a thing which we have been doing very regularly, but there are so many changes which have taken place in this process, and let us see what are the changes which have taken place and how we can adapt to the new changes which have taken place. And we know very basically that there is a passage which is blocked as a nasolacrimal duct obstruction, and there is a passage here. Dr. Grover talked about this part, which we are now talking about is lower part. And so the common symptoms, as we know, are very simple, and we need not go into the details of these symptoms. And this chronic dacryocystitis, as we are calling, is they say is the commonest oculoplasty surgeon one comes across. And that is the thing which we are going to talk about. We are not going to details of the basic, but the approach which we should have to overcome this particular complication is there is a skin approach which we are normally doing, and what we are doing is passing the opening into the nasolacrimal duct and going to the nose. In between, Dr. Pawar had started doing some surgery which was a Pawar's implant, and where we are putting the intracystic implant in the sac, and then there is a communication from the conjunctiva into the sac, and that was a Pawar's implant which was made up of the silicone, and that was very popular, but we found across so many complications with that. Nowadays we are coming with another approach, and that is passing through the nose, and the endonasal approach is considered to be a good one, and they say the skin approach or the conjunctival, the classical dacryocystitis is out of date, they call it. But let us see how people can adopt to the new endonasal approach for the lacrimal sac opening. And this can be done with the help of the laser also. So laser application will produce a cutting of the tissue, and that will produce a little less bleeding and better acceptance of the things. Endonasal endocanalicular laser is sometimes used by people, and they pass the laser into the canaliculus, go into the lacrimal sac, and then they do the laser so that everything is open. That is another opening. There is another thing which we can do. And lastly, we are coming across a microsurgery, where people say instead of doing anything, why not to do a destruction or removal of the fibrous tissue, which can be make the passage patent. So external DCR, as we are calling, is a commonest surgery which we are doing. Lacrimal sac flaps are made, and they are then anastomosed to the mucosal flaps of the nose by breaking the bone. So this is a video to show you that the incision, as we know, it has to be done on the skin. About 1 inch, 1.5 inch incision is put on the skin, and that is very close to the anterior lacrimal crest. Once you put the incision, you separate the fibers of the orbicularis oculi muscle. This is the separation of the fibers or the periosteum on the surface of the bone. Now this sometimes can be very problematic, because once you cut the bone, at that time you might be damaging the orbicularis muscle, and that can bleed a lot. So you should clean the bone properly and then go on cutting the bone. So once the bone is visible, you start punching the bone. So that should not damage the orbicularis muscle. And this opening, so many people say you should pass your finger and find out how much is the size of the opening. But you should have a sufficient opening to see the underlying mucosa. You can see already there is a nasal mucosa which is visible. Once that is visible and enough size of the bone is cut, you can open the punctum and pass your probe to see or visualize the sac part. Once you do this thing, you can cut the sac part into the two flaps. Now so many people can inject some visco material inside or some dyes inside which can visualize the sac, but it is not necessary many a times. So once you have the two flaps of the once you put the incision on the flap, you can definitely see the pack which we have put inside. So that is a opening into the mucosa. Once the mucosa is open and once the sac flaps are made, you can have the suturing, at least 3 sutures you pass inside, so that there is a good covering and good opposition of these things, and which is covering the bony part of this thing. And these 3 sutures can make a very good bridge between these two, keeping the opening open, and there is no question of getting it closed. So a sufficient opening on both the sides is very, very important. Previously we used to have the posterior flaps also, so that there is a chance of success. But nowadays people say that the posterior flaps are not necessary. So you can sacrifice the posterior flaps on the both sides, and you take only a very substantial anterior flaps, which will be just enough for keeping the opening intact. So after just sacrificing the posterior flaps, you can suture the anterior flaps very nicely, and then you take the 2 layers, the subcutaneous and the skin. At the end, I would like always time, which we normally forget, is to take a cannula and do a sac syringing, right? This will not only tell you that it is patent or not, but sometimes there is an opening, or there is a just the opening of the canaliculus inside may not be enough. So that can be done with the help of this thing. It will post inside and tell you that that is definitely lower part of the sac is open. The problems with this surgery which we come across mostly is the bleeding most of the time, right? There is a lot of bleeding and we are not able to do the proper surgery. So what we should do is a pre-operative history taken, and anticoagulants, which most of the patients in the old age are having it, so they should be stopped. Bleeding tendency is there, you should also have the history of the bleeding tendency. Investigations, BTCT, very simple investigations you must do before the surgery. Medications which can be put inside the nose are the decongestants, which will definitely make the bleeding tendency less. Vasoconstrictors, like one of the things which have gone is alpha-gun is a drug which is available, and some people do put the alpha-gun inside. We also put this thing, and that will reduce this bleeding during the surgery. Nasal pack, very nicely done, is a very, very important step which you should be doing. And on table there is 2 things which we have nowadays available, is the suction and the cautery. And our incision is most of the time very near to the anterior lacrimal crest. So if your incision is there, we are not damaging the angular vessels. So that will reduce the amount of the bleeding which is taking place. And one of the things which have been done and which we have been doing is a tranexamic acid, which is used maximum in the gynec surgery, is a very good drug which will reduce the amount of bleeding during the surgery. Post-operatively, there is a problem with the scarring, right? Most of the people say why you should not do the external DCR, right? Scarring. But the scarring which we are making nowadays is very close to the anterior lacrimal crest, and there is not much of bleeding which is taking place. Second thing is a failure to make the nasal mucosal opening is sometimes a failure, and that you should be sure that we have opened the nasal mucosa. Intubation and local mitomycin C application can be done to prevent the failure. So these are the two things which are to be used for this prevention of the recurrence. Advantages of this thing is ease of operation. Instrumentation is easy, cheap, but there are scars. Sometimes people say that is scars, but not much. Bleeding tendency is there, and nasal pathology, if it is there, we cannot tackle with the external approach. So these are some of the disadvantages. Pavar's intracystic implant was very popular in between, and we have also been using it. But nowadays we see that it does produce reaction. There is an extrusion of the material. But there was an article very recently in the Indian Journal of Ophthalmology when they say that they had a very, very good success rate, and with the silicone implants which are available, you can have a very good result. A very good thing is that nowadays we have the endoscopic view which is available, and so that you can see where the tube is situated, right? You can make a proper position of the tubes. So that will help you in positioning of the tube inside, and that will not touch the opposite border, right? So that will not be the blockage of the thing. So intracystic implants are also popular nowadays. A small video to show you how it
Sir,
is to be done.
Can you please show endonasal DCR for what people?
Yeah, we are
Next
doing it.
presentation
Yeah,
is
yeah,
already
just
on this.
just after
Okay.
this, yeah. Endonasal DCR, we are doing it.
Yeah.
Just
so
this
it will be-
Pavar's implant is still, because there was an article very recently in the Indian Journal of Ophthalmology. I have given some importance to it, that we can do this thing in some of the patients who are to undergo cataract surgery, right? And they have a big mucosal swelling. So what to do? In those cases, you can always expose the mucosa, and then you put an incision inside, and then pass the tube inside. So that is how the operation is done very easily and without having any bleeding inside. So this is a Pavar's implant which we have been doing. Just remove everything from the sac, and then with the help of a dilator you can pass it inside and open the sac swelling, the bone, as well as the mucosa. All the three things are opened up in one entry inside. After you are sure that you have got enough opening, you can pass this fluid inside and see that it is open, and Pavar's implant is inserted inside with the help of the inserter. So once it goes inside, you can take sutures to close the sac. So after passing it inside and be sure that it is inside the sac, you can close the sac, and you should be going inside, down and out, down and inside, so that it doesn't touch the medial wall of the nose. So that will be sure, and this is how it is performed in some of the cases, right, where there is not a possibility of doing an external DCR. So ease of this thin scar is not there, and we can say it can be done with the help of this thing. Endonasal DCR is one of the things which has come in the field of ophthalmology. This is better done by the ENT surgeons, but we have also started learning this thing, and these are some of the advantages, that you have the scar which is not there, its bleeding is less, and we are opening up this area from which you can have the communication. And this is endonasal DCR. We have a small video to show you this thing. After injecting the xylocaine and the adrenaline inside the nose, in the middle meatus of the nose, and then we What we require is a training, most important thing is a training, and you should have an handling of the endoscope which is there, which requires is little training for the ophthalmologist. The ENT surgeons can do it fast, very easily, but we have a little difficulty. What we do is put an incision and remove the nasal mucosa with the help of the instrument, and then what we're doing is removing the mucosa and exposing the bone underneath. So once you have exposure of the bone, what you can do is to pass the punch inside and open it on inside. A substantial opening is made with the help of the punching, and during this time, you can see there is hardly any bleeding which is taking place. Once you have injected xylocaine adrenaline inside, the bleeding is going to be much less, and you can see that the sac has started being exposed. You have a big opening of the sac exposure, and that can be done to make the opening of the sac. Once you have the substantial opening of the sac, you can put an incision on the vertical incision on the sac, and that will open up the lacrimal sac. So once you have enough opening of the sac, you can take the crescent knife or the sickle knife and put it from the beginning of the lower part, right? So because of the gravity, everything will come down. Mucosa, you can see here, is very thick. So instead of just passing once, you might have to do 2 or 3 openings, and every pus has come out. So this is opening of the sac. You remove the pus from it, you wash it out, and then what we do is to flatten the posterior wall of the mucosa, the lacrimal sac, and we are not going to take any sutures here, and that is one of the I would say is the weakness, that we are not fixing the posterior wall of the sac inside. It remains as such open, and you can scrape it, you can marsupialize the whole thing, and sometimes you can put the glue on the posterior side to fix it, or remove the sac. Right? Posterior wall can be removed by punching it, so then the opening is present, and that is how you can do it. Sometimes you can pass a tube also inside, and you can also use mitomycin C in these cases. But that is a little difficult for these people, right? So these are some of the advantages and disadvantages. The only advantage is, I would say, is you can tackle some of the things which are pleasant in the nose. The nasal pathologies can be tackled, and that is how you can make this thing. But I would say still it is a little problematic thing. A small video.
I have later on.
Okay. So I think we can have this thing in the last lecture. So this is a laser assisted external DCR, which can also be done, and it is done sometimes with the help of the diode laser, in which you can damage the bone as well as the mucosa and the lacrimal sac, and that is how you can make the opening. Lastly, coming to a procedure which is a microsurgery, just a name to come, and this is going to be a future when we are removing the fibrosis from the nasal, the lacrimal passage, nasolacrimal duct, which will not produce much of the problem. But people say that it has become a appendix, or it has become a discarded thing, but still I think external DCR is still in vogue, and everybody would like to do it. Thank you.
Thank you so much, Nitin sir, for covering all the things.
Book is published by Dr. Muhammad Ali Javed, and his book is very good, which is giving the subject very vast exposure. Thank you.
Thank you. Thank you, Dr. Nitin. And next we have Dr. Shreya Shah, our chief instructor and a very high volume oculoplastic surgeon. They have managing a hospital which handles huge volumes in the heart. It's a pleasure to see that hospital in a rural location doing such a high quality and high volume work. And Dr. Shreya has built a very good quality work in oculoplastics, high volume and with lot of publications. So we'll look forward to her innovations and her small incision lacrimal surgery.
Thank you so much, Dr. Grover sir, for the nice introduction. Thank you, sir. I'll just talk on small incision external DCR. Still it is external DCR, and why would we call it a small incision, we'll come to. In our hospital till now we have done 5447 lacrimal surgeries, and out of that 4195 are DCRs. Others were canalicular and incision and drainage surgeries. So we all know what happens. I'll not go into detail of it, but if you are learning, this thing happens later on at the old age sometime, and it NLD closes by any fibrosis and the fluid comes back. That is called Roplas positive, what we call it as a. In children it is very easy. In children it's very easy just to break the bone or membrane which is lying in the inferior meatus. Just pass the probe, break the bone and come back. It's easy. But what is Dcr rhinostomy? We all know that we are making one big hole in the medial wall of sac, nasal mucosa and the lacrimal bone, and the fluid passes through it. What we call it Dcr rhinostomy. Till we have done 14-15 surgeries of that. Dr. Nitin sir has showed very nice videos about it and flap and everything. It's wonderful results. Sometime, but because of large scar or keloid, patient may not like this on the face. So then came the transcanalicular laser assisted DCRs. We did 648 such surgeries where we just passed laser from the upper punctum and endoscope from the lower punctum. We make an opening looking at the endoscope. Once the opening is done in the middle meatus, it is very well seen and we can intubate it or not. Sometimes with this endonasal Dcr or any kind of Dcr, you can see the patient was operated at 9 o'clock and at around 6 o'clock he developed emphysema. So you need to, as Dr. Grover sir rightly said, you need to tell them not to blow the nose. Then came the endonasal Dcr. We did certain 18-19 surgeries of that also, and Dr. Nitin sir has already explained everything about endonasal Dcr, which needs quite experienced hand, and sometimes we may have to call ENT surgeons. So then we decided to do transcanalicular manual DCR, which is, we call it as a cannula DCR. We did in such 7 to 9 patients after just giving the anesthesia, local infiltration. After dilatation of both the puncti, both the canaliculus. So this is the cannula, which is blunt tip and side pot. It is around 22 to 23 gauge cannula, 1.5 gauge, 1.5 inch long. We just pass through the lower punctum as we do with probing. Then we keep it hugged with the bro and make around 40 to 45 degree and just push. It breaks the lamina praeparia only because other bones are very, very strong bones. It doesn't go anywhere. And we can just confirm through the nasal endoscope. We just confirm the patency. So we did this study. We did such technique in 7 to 9 patients. But later on, because there was no intubation, usually it closes because it's very, very, very small hole. So we just took the spinal needle, or we can take the laser needle. After doing all the technique of cannula DCR, after confirming the patency through the nose, we just pass the proline suture through that. We retrieve it back through the endoscope, take it back to the nose, we kept it, and then we published this article, and we did many more cases in this. But again, it has flaws, and it was a 52.4 success rate with mean follow-up 252 days. So then we developed intracat DCR when there is a sac scarring also along with the proximal end intubation. So we take 22 gauge intracat, we use the Teflon sleeve of that. Being the experience of passing the cannula, doing the cannula DCR at 40-45 degree, we use the same thing. We made it little vertical, pass into the middle meatus, look through endoscope, confirm the patency. Then we pull the piston, and then we kept it. We did such 34 surgeries. But you all know that it is not an inert material. You need good inert material to have. So we developed simple newer technique, which is an external DCR. It is simple DCR, what we previously were calling it as a power DCR, but it's not actually a power DCR. It is, as I said, after anesthesia. This is the actual technique after dilatation. So this step is important. When I pass the cannula and holding canaliculus and common canaliculus in my hand, and then I put in the nick, it is very, very small, 1 millimeter nick. I do cannula DCR. I confirm patency on table, sometime through endoscope, or patient may reply. Now I extend the incision because my cannula is already in the sac. So you don't have to confirm, and you don't have to find the sac. Once you, with the railroad technique, if you confirm the sac, you can just introduce the bone driller, which is around 3.5 millimeter in diameter. After drilling the lacrimal sac wall, bone, and the nasal mucosa, you can just introduce any kind of implant. Here we are implanting silicone implant. Even you don't need sometimes suction. It works fast. Once it is done, with the anti-clockwise, just remove and confirm the patency on table. And then I suture the sac with one, it's very good flowing of fluid, with one suture on the sac, which usually I take buried suture, and then 2 suture, I'm so sorry. And then 2 sutures, 1 suture only per string and 2 sutures on skin. And I measure all my incisions after surgery. So you can see it is usually comes sub 5 millimeter. So nowadays people are operating even SICS through 5.2 millimeter. So this is, we can confirm it, any kind of tube through the nose. Even sometimes you don't have to confirm, it drains very, very nicely, even if you are just putting the saline on it. We have done all the surgeries and we have measured all the incision. It's almost sub 5 millimeter incision. The same technique we have used even while doing this surgery. We all know usually we don't cut angular vein because if you are well versed with anatomy, you don't do. But there are some anatomical variations. So during my second incision, I just cut the angular vein. Once I did that, you don't have to stop there. You don't have to have fancy suctions and anything. You just go ahead with the surgery. By the time you operate, by the time you put implant, and then your drill itself becomes a tamponade, and then slowly you can perform the surgery. At the end, you can ligate the vessel. We did the canalicular DCR along with this, so we can confirm we can use the same Teflon slit along with this sleeve along with it. And this is the scar. So patient wants no scar, though there is external DCR. What we were expecting out of this, in the late stage, it is expected that the presence of tube into the lacrimal bone halts the process of healing of osteotomy, facilitates the migration of sac epithelialization around the osteotome and goes along the nasal mucosa, and this forms a permanent opening with a small incision, what we do with external DCR. So even if the tube is removed or extruded, you don't have to do anything. Post-operative management with as with all kinds of surgery, we prescribe anti-inflammatory antibiotics, and we follow up the patient for 7 days, 1 week, 3 weeks and 3 days. We don't do syringing until unless the patient is not telling about the epiphora. No need to just intervene. When patient is happy, you be happy, don't intervene. What can happen in later stage? A plugging of the distal end of the tube can be there by mucosa, by discharge, or by blood clot, or it can be just simple nasal mucosa which covers the tube. So what can happen? Here you can see, I only can see, so we have devised newer technique that mobile is hold and everybody can see what is there in the endoscope. So in OPD base also you can teach your students. So when there is early cause, you can just simply do this is how we recorded through mobile. So you can just simply clear the crust and the discharge which is covering the tube holes, and once it is clear, you just confirm the patency on the OPD base only. So you have to do endoscopy repeatedly. You have to keep one endoscope in your, and sometime we may have to take help of dacryocystography. So this is actual position funnel and is lying in the sac. What Dr. Nitin sir said, it is truly intracystic implant. It should pass in that way, and then it drains the fluid. But this is called intracystic position of implant. When there is covering of mucosa, we have our own cannula DCR, break it, and it works very well. Sometimes the thing can go that you incorporate, you take both the sac wall, so it becomes transcystic position. That is a difficult thing to handle. You need to know how will you diagnose, was it a transcystic? There will be patent syringing on table through the wound, but when you do through lower punctum, the sac will not swollen, there will not be patency because it has already taken 2 walls in that, and there will be constant epiphora. Sometimes this is the way you put, you are happy that you have put the tube and the patency is there on the table, but this is extracystic implant. You have just bypassed the sac. So in that condition, how will you diagnose? Again, when you do syringing through the incision, it will be patent. There can be constant epiphora, but there will be bulging of sac on syringing. Or sometimes just migration of tube happens in the sac wall. What will happen then? The surrounding the tube, there will be a fluid collection that we call it as a sump syndrome. Sometimes comes as an extrusion of tube, and don't worry, whenever there is extrusion of tube, you can do repeated surgeries with the same small incision technique. But sometimes it is just stuck in the bone, then you need to remove properly. Now we say that there is already plugging of tube, so we are coming up with some more newer modification. We are passing bicanalicular intubation tube through the already placed silicone tube. So these bicanalicular intubation we can keep for 6 months, so there is no chances of blockage. So you can see bicanalicular intubation tube passed. We have done external DCR with silicone implant, and they are coming through the silicone implant. We are tied to the nose, and then later on we can remove. So complication, as sir said, it can be a granuloma. Other things we have already covered how the complication happens. We need happy patients. Thanks to my teachers. Thank you. Thank you all my co-instructors. Thanks a lot.
Thank you, Dr. Shreya. As the talk illustrated, the high volumes of work that she has done has brought about all these innovations for simplifying the procedure and for making it more comfortable for the surgeon. Thank you for that lovely presentation. Next, we have Dr. Arun Samprathi, who's a high volume surgeon again, trained at Arvind Eye Hospital, who is working at Bangalore in his own center, the Samprathi Eye Hospital, and we look forward to listening to him talk to us on the issue that interests us all, which always elicits the maximum discussion: congenital nasolacrimal duct obstructions.
Good afternoon, everybody. First of all, I'd like to thank Dr. Shreya for giving me this opportunity to be here. So I'll be today talking about management of congenital nasolacrimal duct obstructions. So we all know the anatomy of the nasolacrimal duct. See, this is a sac and this is a nasolacrimal duct, and the obstruction is usually at the valve of Hasner. So it's a very common condition affecting about 5 to 20% of normal infants. And before we go into the treatment as such, I would like to just touch upon the embryology of the NLD. So lacrimal sac is derived from the ectoderm of the nasomaxillary groove, and then that thickens to form a cord of cells, and then it sinks into the mesenchyme like this. And then in the 3rd month of gestation, there is a breakdown of the central cells, and that forms the lumen, and this is how the lumen is formed. And then the NLD is the last portion to canalize. So this has to open into the inferior meatus. So this is the last portion to be canalized. And this is where we get the congenital nasolacrimal obstruction, because this fails to canalize. This membrane fails to break, opening into the inferior meatus. So that's when we get the symptoms of congenital stenosis. So usually presents with the unilateral watering and matting of the lashes. And when you press on the sac area, you may have a purulent discharge. Sometimes it can have an acute infection causing acute dacrostenosis cystitis also. Whenever the sorry, there was one. This thing is not happening. Okay. So whenever the obstruction is at the valve of Rosenmüller, you will just have only watery discharge. Wherever the obstruction is at the valve of Hasner, which is the most common type, then you will have watering plus mucopurulent discharge. This is a very simple test because most of the time we will not be able to do a syringing in these children. So we are not sure whether it is an NLD obstruction. So this fluorescein dye disappearance is a very simple test. You just stain the 2 eyes with a fluorescein dye, and in the eye which has a duct obstruction, you will not see the dye in the nasal cavity. So the tear film will be full of fluorescein dye, whereas in the normal side, the dye comes into the nose and the dye disappears from the eye, then inferior this in conjunctival sac. So this is a very, very simple test to confirm the diagnosis of NLD obstruction. It's also important to remember these children are having associated amblyopias, especially the anisometropic amblyopias. So we should be very, very careful that we should not miss this anisometropic amblyopias, and cycloplegic refraction has to be done in every child who presents with watering. Differential diagnosis is very important. We may be missing a congenital glaucoma, so that's very, very important. And also we should inspect the puncta. So many times you post the patient for probing, and on the table you find that the child has a punctal atresia or a punctal stenosis. So it's very, very important to preoperatively diagnose this punctal atresia. And sometimes there may be a fistula between the sac and the skin. So what happens naturally, like if you don't do any treatment for these patients? It's found that only 37% of the infants at term have a patent NLD, but most of them canalize by the age of 2 months, and only 5 to 6% presents to the pediatricians. And of this, 90% of them resolve by the age of 1 year. So only when it's persisting beyond the age of 1 year, treatment may be necessary. So management depends on the age of presentation of the child, the severity of symptoms, the concern of the parents, because parents are unduly concerned about the watery eyes, and general health of the child. So most commonly used treatment is the Krigler's maneuver. As we all know, it's a very simple procedure which the hydrostatic pressure is applied onto the nasolacrimal duct so that it opens up. So this is the correct way of massage, because most of the times when the pediatrician advises massage, they'll be just rubbing on the sac, and there is no pressure as such, because basically you have to give pressure on the sac so that you push the fluid downwards So one fine day that membrane opens up. So basically this is a hydrostatic massage wherein you're trying to push the fluid down to hit the valve of Hasner, the membrane covering the valve of Hasner, so that it breaks. So the proper massage is very, very important, otherwise there won't be any effect of massage. And also we have seen a lot of times even antibiotics such as moxifloxacin being prescribed irrationally. So it should not be used unnecessarily. Only when there is a evidence of infection it has to be used. Coming to the surgical management, probing is the age-old method and has been very successful. There have been a lot of issues. What age to do the probing? There have been people who probe as early as 3 to 6 months of age, whereas some people prefer to wait till the age of 1 year. Also in the West, some people have been doing something called the office-based probing, wherein without anesthesia they just hold the child, mummify the child and then just do the probing. But I feel it's a very risky procedure, may create false passages. So basically in probing what we do is we overcome the valve of the obstruction at the valve of Hasner. So you pass a probe, the Bowman's probe, after the dilation of the punctum, and then you try to puncture the obstruction which is there at the valve of Hasner, and it can be confirmed by using another metal instrument through the infimmatus, or Dr. Shreya uses an endoscope to confirm that one. So this is a procedure of probing. So just do a punctal dilation, and then most important before proceeding with the probing is a control of infection. So if there is infection either in the sac or in the nasal cavity, the chances of failure are very high. So control of infection is important. So once you pass the Bowman's probe, first vertically, then horizontally hit the bone, lacrimal bone, and then you angulate it downwards. You should not give any undue force. It just goes gently into the duct. And once you feel that, then you just push it forward. You just have that feeling of giving away. And once you do that, we also do something called a reaming, just to enlarge that opening. And I usually confirm the opening by using a dye, so that you can see in the nasal cavity whether the opening is there or not, or you have created a false passage. So during probing we may have a membranous obstruction or sometimes a bony obstruction, which again has a high failure rate. And failure of probing is usually because of the improper technique. You create a false passage, or in presence of infection. As I said, infection control is very, very important. Or there could be a bony abnormality, or you operating on a very elderly child, which the bone probably is not responding to your treatment. Probing is an invasive and a blind procedure, as I told you, so it may create bleeding. False passage is quite common if you are not careful with the technique. And inflammation with subsequent closure of this thing is also there. So as I said, many ophthalmologists have also shifted to use of endoscope along with the probing, and this has improved the success rate because you know where exactly you are pushing your probe. Sometimes if there is a failure of the probing, you may actually attempt a repeat probing. Many times this succeeds, but if it doesn't, we can do a silicone tube intubation of the nasolacrimal duct, so which also gives a good results, and we leave behind this for about 3 to 6 months and then remove the tube. More recently, balloon dilation of the balloon dilation of the NLD also can be done, yeah, but it's little expensive. I have no experience with this particular technique. Other modalities, of course, the conventional and the endoscopic DCRs, which have already been very nicely highlighted. So in conclusion, NLD obstruction is a very common disorder, and most of the time conservative treatment with the Kliegler procedure cures the obstruction in almost 80 to 90% of the children. In the remaining 10% who may need the intervention, most of the time probing is sufficient, and it's a very simple procedure which each and every one of you can do. And the one thing I would like to highlight is not to miss the refractive error, because any child presenting to you with anything, refraction has to be done so that we pick up this anisometropic amblyopia early. Thank you.
Thank you, Dr. Samprathi sir. There is some any question for Dr. Samprathi sir?
Yes, sir. You can tell, sir. It's okay.
Since
So the elder upper age that I have done, even I've tried in an 8-year-old child and have been successful. But most of the this thing literature says 3 years. Up to 3 years it's very successful. But just to avoid a DCR, I have attempted in an older child also, but I have fortunately been successful in that.
Thank you.
8-year-old child I have done, sir.
Thank you. Yes.
Ah,
We have
yes,
published
yes.
that
I think it
study,
should be
works.
attempted because it's
You should always attempt.
yes, sir.
Yes.
Yes, sir. It's a very simple procedure and doesn't need much this thing. So I think it should be attempted before you go in for a DCR.
So how many of you are coming across the lacrimal? So you want to ask something?
I just have a suggestion. Please excuse me for my bad throat. There is a now conscious sedation pediatric dentist use them. And there the deglutition reflex remains okay. So there you can simply after probing,
Can
you do the
confirm.
syringing
Very
and
nice.
see the deglutition. If it is okay, there is no need to put the endoscope or any diet.
True, true, absolutely. So
Normally I would do only twice. If two probings are failed, then go for a silicone tube intubation.
and sometime only failure of probing happens because if you know the exact anatomy of NLD, surrounding which is a vacuoles which is made by blood vessels. So sometimes you enter your probe into NLD itself rather than breaking the membrane. So that gives bleeding and that heals fast because you have not already opened the thing. So you need to take care of that. How many of you are coming across the lacrimal injuries? Most of the people, right? So many. So I have just 5 minutes video if you would like to say. There's some innovation that you can find out the cut and easily. Are you ready, sir? Thank you, sir.
Just wanted to have a little discussion on how many of you have shifted to endonasal Dcr? Only one. And rest of the people, they are doing external only, right? So still I think Dr. Grover also will have the comments. Still it is difficult for the ophthalmologists to go on to the endonasal Dcr. That share goes to the ENT surgeons only. Yeah, people have asked you to shift to the endonasal, yeah. Yeah, they do it in your clinic, yeah, that's right. Right, right.
Yes.
So that share has definitely gone to the end, the ENT surgeons.
Just tell me.
Till the talk is ready. Ready?
Yes, sir.
Okay.
Sir, if you want to say, continue.
I just wanted to say that
Yes, sir.
the most important thing is two key things. Take all the efforts for good hemostasis, because if there is no bleeding, DCR is a relatively simple surgery. Second, the only difficulty with this surgery is that you're working in a depth, and a good illumination and good visualization is important. So if you start using a headband light, sit on the side rather than sit on the head end, then you find the visualization is very beautiful. If you do take all the steps, including nasal mucosal packing well, which goes into the middle meatus by direction which is towards the medial canthus, and has a high content of adrenaline, 1 in 30,000 if your anesthetist permits, otherwise 1 in 60,000, 1 in 80,000, and leave the pack in for 5-10 minutes. Give your injection in the local area with 1 in 80,000 adrenaline if possible, which is available as dental ampules and dental vials also. You can use that and wait for 5-10 minutes before starting. Of course, blood pressure is controlled well, and you've taken care of any Disprin use, etc., etc. So if you follow those things and follow the exact anatomical planes, if it is bloodless and you're seeing well with a 2.5x loop with a headband illumination, if you have that, DCR is a simple surgery. If your visualization is not good, or if your light is not going in that direction, or if there is bleeding, only then it is a difficult surgery. If if you have a bipolar cautery of any kind, even from your phacoemulsification machine, that is, of course, you just need bipolar cauteries. For monopolar cauteries, there are a number of options which are now available. The radio frequency units are now available. Indian ones for 25,000-30,000 rupees. Several companies. Bosco is one of them. So don't cut the skin with that. Deeper planes with that. Stay away from angular vessels. Stay in the medial part. So just those basic few tips. If there's no bleeding or minimal bleeding, which is easily controlled with hemostat, with your bipolar, and if you're using a headband light sitting in the right position, then it's an easy surgery. So only because of the uncertainty about bleeding, uncertainty about visualization, that it becomes a difficult.
And how to tackle that very friable sacs? Many times we see very thin and friable sacs. Hold it under.
So in those cases where the sac is small or it's scarred, or if there is any other difficulty anticipated, think of only a big, large anterior flap. Tent up your with your probe. See if it is a small sac. Just make sure that you are making as large an anterior flap as possible. Don't think of posterior flap, and use anything that is present in front of your probe where it is emerging, and tent it up. What happens is that you give a single cut sometimes and it has not gone through, because the sac, as Dr. Nitin showed, it can sometimes be very thick and you need second incision till you have exposed your, if you have exposed your probe coming out and you have that anterior tissue in front of it, then the rest can be easy. Mucosal, if you made a good bony ostium and made one large mucosal flap, anastomose whatever is available on the nasal side as an anterior flap going into the nose, and whatever tissue you have in front of the canaliculus, it will work.
So what happens is we lost the sac, anterior wall of the sac. Many times in the retrospective, we cut that.
So just try and find whatever tissue you can. Make a larger nasal mucosal flap. Yes. See whatever you can mobilize. Then dissect a little more to the area behind the common canalicular opening. Just dissect the sac a little more from the surrounding tissue on the front side, and then you can mobilize it, cut on the above and below, and you will have some kind of a flap. As long as you have a common canalicular opening which is well defined, you will find something or the other to suture to a large nasal mucosal flap. And if you had any difficulty in good anastomosis, then probably use intubation as well, and maybe a little mitomycin C also for 4 minutes. The same strength that you use for your trabeculectomy, 0.4 milligram per ml.
Thank you so much. We all know what we do to find out when there is a common canalicular cut or medial cut, and I'll not go into detail of it. I am just showing one simple way where definitely you can find out, until and unless you don't want to do, because 50% are fairly asymptomatic when one canaliculus is working, but as much as possible you should do the canaliculostomy as you get the canalicular injury in order to avoid lifetime epiphora. So primary repair is always definitely important. Secondary can be done. As Dr. Grover rightly said, you need to have controlled condition in our OR, proper anesthesia setup, magnification, optimal illumination, and of course endoscope if it is available. These are the instruments required from OT, and these are from surgeon, because thorough understanding of medial canthal anatomy is must. So first step we always do is inspection, and we try to find out the Flaringa's ring reflex to find out the severe cut medial end of the thing. If you are lucky enough you got it, that's fine. It's not always so. So sometimes you can just take the help of methylene blue fluorescein dye, just passing through that, sometimes red row technique. But methylene blue, when you inject from uninjured punctum, that creates the mass. But once if you are able to find out the canaliculus cut end and Flaringa's ring reflex, you can definitely do canaliculostomy through anything. And the fourth step is always suturing. Mini monoca also you can try, which is quite expensive thing, and it has got its own advantage and disadvantage. So So sometimes you can just use the Teflon sleeve of 26 gauge intracare. That is done, and I learned from Dr. Grover sir only this technique, which is easily available in your OT. But for that also you need to find out the cut severe end of the canaliculus, which is not always so. So if one such day I was doing this and I could do, and sometimes this Teflon also gets extruded and gives inflammation. Then came the pigtail technique, which has got very damaging end, and it's very thick metal, so sometimes it can create the false passage. Based on this pigtail, one fine day I was not able to find any way, all the ways I tried, I didn't find the cut medial end. So what we did, you can see it's herbable lines. So it was second day cataract surgery. Patient came with a canalicular injury. So we just do probing. We confirm the distal cut end. I took the 40 proline needle, cut it through mosquito forceps. The cut end I just made blunt with the emery stone in operation theatre itself. Once it is done, you can see it's totally blunt tip. Once it is done, you can hold with the curved needle holder, pass through uninjured canaliculus. This thing cannot go anywhere else other than the medial cut end. So you can see it is coming out easily through the medial cut severed end of canaliculus. So this is the way you can work in your area. Don't just waste time to find out the cut end. Take this. See, now we can see the flaring gas ring reflex from where it is coming. And the advantage is the same proline you can use as a stent material, that is a canaliculostomy also. It is done in children also. Here we took small suture. So that was a 40, here we could took 60, and this is the way pass. Once we pass, you can just pass through the cut end. So this is the way we have done this procedure. It is already published, and we are coming up with the newer technique. It is already under patent, so I cannot show you, but that you will be benefited with this. Thank you so much. Thanks to my co-instructors. I'm so grateful. Within short time they have come. So we'll have one picture, and I'll just the next session chair can just take over. So what will be there? Actually, whenever you are doing this, you must confirm the scale of your that happens in our teaching institute also. What happens once they are doing their syringing, they are actually creating iatrogenic damage to the canaliculus. So in that case, when there is little bit stricture, and then you'll find that it is clear fluid is coming, and they will label that's common canalicular block or there is partial NLD block. In that case, sometimes same result comes when your previous optometrist already had filled the sac with the fluid, and now you're doing false passage. So that comes immediately. So that you need to take care. It's not actually true NLD block, and the thing is later on it actually becomes stricture. So it's better to teach optometrists properly. We teach in that way that don't push, pull the lead laterally. That is the only way to do probing. That is the only way to do syringing. Never ever pull your cannula, push your cannula, pull the lead. Hold the cannula there, pull the lead. It will go in the canaliculus only. That is the thing comes. That glaucoma drug you all know, anti-glaucoma drugs. Post-cataract surgery we have not seen. That can be just because of precipitates of steroid, which is actually plugging the punctum.